Well, good afternoon, ladies and gentlemen, from a cold and windy and wet Cape Town. It's wonderful to have rain over here, maybe not as much as the rest of the country, but we still welcome a little bit of the old precipitation. It gives me great pleasure to be on this webinar this evening with Professor Pistorius. He's been on many a time. He certainly doesn't need an introduction, but he will get one nevertheless. Professor Pistorius is head of the Fetal Maternal Clinic and Scanning Section at the Panorama Hospital. He's a wonderful, wonderful resource to our country. He was instrumental in organizing the FIGO meeting recently in October in Cape Town, and I'm hoping he's going to be at SASOG. I'm also going to give a little punt for SASOG. Many of us are going to SASOG, and that is in August in Cape Town, but technically at the Century City venue. So if you can manage to book, there's still time, and there's still some places available. So it's wonderful. I'm sure Lo will be presenting at the SASOG meeting. Now, ladies and gentlemen, as you usually know, the co-host is Professor Steve Jeffrey, but as we mentioned last week, Steve Jeffrey is in Azerbaijan. And hands up all those that could point out Azerbaijan on the world stage. The map of Azerbaijan is very obscure. And as you know, Azerbaijan is right next to Iran. So I'm hoping he's back by next week without any injuries. Professor Pistorius is going to be speaking, as you can see, on congenital CMV, cytomegalovirus, new hope for an old problem. And it's wonderful to have you, Professor Pistorius. He, as you know, used to be the professor at Utrecht in the Netherlands. It's a wonderful city. And I'm hoping he's going to be showing us some of the pictures of Utrecht. I spent many a happy time at Utrecht as well. And so you'll recognize these pictures from his old alma mater. Professor Pistorius, new hope for an old problem, and welcome, and start sharing your slides.
Great. Thank you, Peter, for that very kind introduction. I think in disclaimers, the only disclaimer I have is that I think the only change since they made me a professor is that suddenly I've become much more scatterbrained, so apologies for anything related to that. Now, initially I thought to talk about gastroschisis from some very exciting stuff that I saw in Houston recently, but I'm also going to do a small punt for SASOG, and so I'll circle back to that. But maybe just a couple of pointers. I always thought, if a baby of mine or my daughters have an abdominal wall defect, I would want it to be a gastroschisis, because 90% of the babies survive. There's a low risk of associated anomalies. 90% of the survivors do well. And I mean, those stats sound really good, but I've started wondering about that. And I'm not showing a picture of Utrecht, but of a flamingo, because in Utrecht, I was part of the flamingo study that stands for something like fetal markers to predict neonatal gastroschisis outcome. And that actually brought home to me what has actually been known a long time, is that if we look at the babies born with complex gastroschisis, which is nearly 20% of this cohort, there's a 10% of those babies die. They don't make it neonatal. That's now regardless of the 10% around about there of antenatal demise. And if you look at the time to full enteral feeding and the length of hospital in these babies, it's really horrendous. These babies have a median stay of 99 days with a range 31 to 203 days. So they can be anything from 1 to 8 months in a hospital. But even the simple gastroschisis that we would expect to do well, they also have a median stay of 37 days, which is a long slog before your poor baby goes home. But there is light at the end of the tunnel, and that light, I think, is found at the end of the fetoscope. But I'm going to leave you hanging there. You have to tune in for the next season on Netflix. No, not Netflix, SASOG. And come and listen to Mike Belford when he speaks about fetal therapy. All right. So just a little bit of punt for SASOG as well, and specifically the fetal therapy session. And let's get back to congenital CMV. Now, CMV is something that Evil calls the neglected pandemic. Because you look at the maternal seroprevalence, it goes from 50-60% in the west of Europe through to 90% in South Asia and sub-Saharan Africa. What the seroprevalence is in South Africa, we don't really know. Some laboratory-based data suggests that it might actually be in excess of 80-90%, although it's difficult to tease out the tests that have been done as part of screening. So if we look at moms or females in a reproductive age group, there's a very high seroprevalence, but much of that might actually have been done because of a clinical suspicion of CMV, which would then you'd suspect be linked to a higher prevalence. You look at cord blood stem cell donors, and this is data from the 6 years 2019 to 2025. 2/3 of these patients are CMV positive. And so that brings us to more or less the same as USA and Australia, and that would be patients that pay to have cord blood stem cells from cord blood banked. So probably a very small niche group of patients that can actually afford this and decide to go for that. So definitely not a average South African lady just giving birth, and probably also not just the average South African lady in private giving birth in private practice, because not everyone has the couple of thousand lying around for the cord blood stem cell banking. In the patients that have come back for another stem cell banking, there's been a 14% of seroconversion, which probably then happened either somewhere down the line or in the second pregnancy. And my thanks to Yvonne Holt for giving us these data. So we don't rightly know. Going back to what's known more generally, we know that CMV is the most common cause of congenital infection. Globally, affects about 1 in 150 pregnancies. In Southern Africa, probably around 1 in 100, 1 in 40 pregnancies. And the burden, as I'm sure you're well aware, is that of progressive hearing and visual loss, progressive neurological impairment. And from the other side round, CMV is probably responsible for 10% of childhood cerebral palsy and 25% of childhood deafness. And in fact, after the congenital causes of childhood deafness, this is really number 1 on the list. Question, if we start talking about prevention of congenital CMV, does this occur after a primary or non-primary maternal infection? In Europe, it's estimated that it's about 50-50. And, it might be that in private practice that is the same. We don't rightly know. In the lower middle income countries, there's 3 times the rates of congenital cytomegalovirus, and is 1 in 40, 3 times 1 in 150, probably more or less, maybe even a bit more. And then you might think that, well, if a mom has CMV already, she can't pass it on to her baby, but there is also a high chance of congenital cytomegalovirus after non-primary infection. And although the absolute risk is lower, the burden is higher. I mean, it's the same as with Down syndrome. The risk of Down syndrome is much higher after 35, but there's just so many more pregnant women younger than 35 that there are more babies with Down syndrome born to the younger moms than the older moms. So it's estimated that in the lower middle income countries, probably 3 in 4 of congenital cytomegalovirus are caused by reactivation rather than primary infection. Risk for primary infection would be the younger patients, higher socioeconomic levels with a job, seronegative in a previous pregnancy, oldest child in a creche. And my brother's an engineer, and his definition of a children's party is that where the kid goes with a present and comes back with a virus. And I think the definition of a creche would be where the kid goes with a lunch, with a sandwich, and comes back with a virus. And so the pregnant woman with the older kid in a creche is really a sitting duck for primary CMV infection if she's seronegative. Non-primary infection, perhaps is not a risk factor and generally seen in a lower socioeconomic level. And of course, things like gestational diabetes, HIV, all that can play a role. Now, primary prevention, hygienic measures have been advocated, like not kissing your snotty little daughter who might have CMV. Don't put a baby pacifier in your mouth. Do not share food. Do not share a toothbrush. Wash your hands. Wear gloves. And we all know this doesn't work because there's so much CMV around. And in terms of the pacifier, you know how it goes. First pregnancy, the baby drops the pacifier. You put it into sterilizer and then give it back to the baby. Second baby, you lick it off and give it back to the baby. And the third baby, you give it to the dog to lick and then give it to the baby. So maybe to prevent CMV, you should bypass the first and second pregnancy and just give it to the dog directly. And we all know all the trouble our poor Miss South Africa ran into when she wore gloves when dishing out food. So maybe these hygienic measures are more trouble than they're worth. So shall we actually shift gears and start screening for CMV in pregnancy? And you know the WHO criteria for a good screening test, and definitely CMV is an important condition. Is there an acceptable treatment? Well, let's see that later in this talk. Are there the facilities for diagnosis and treatment? Well, that's going to depend on whether there's treatment. They should be recognized latent or early symptomatic stage, and definitely the mom gets CMV before it gets passed on to the baby, and there might be the window for early treatment. There should be a suitable test with few false positives and negatives. And I mean, we've all ran into the problems of CMV with positive IgMs, and everybody's really up in arms about this, where it turns out that this IgM has just been around for years and years. And in fact, not so long ago, the very same evil said, if you don't have a screening test in your population, don't start it because there's so much false positives. You give yourself a complete nightmare, yourself and your patients. But of course, he's swung the rudder around, and but we'll come back to that. The test should be acceptable to the population. Well, that should depend on what the test is. And then the other big question mark is whether the cost is economically balanced in relation to the expenditure. In other words, you know, is this all cost beneficial, or we're just driving up the cost again? Now, is there a treatment window? And I think one big difference in our understanding of CMV is really that the sequelae of congenital cytomegalovirus following maternal primary infections, again, this is now all about the primary infections, that's really limited to those acquired in the first trimester of pregnancy. And you can see here quite a large group that followed up in different centers in France, that of the patients that developed CMV in the first trimester as primary infection, 32% of them had sequelae, of which about a third were neurological and about 2/3 sensory hearing loss. and none of the babies where it was confirmed that it happened after 14 weeks. Now, the number isn't that huge. That was 64 babies, so you know that the upper 95th confidence interval of a zero denominator is basically 3 divided by the numerator, which is lots of jargon to say that although they didn't find anything, it might be as much as 3 out of 64, or let's say about 4 or 5%. In the third trimester, also none were found. These data and others were included in a meta-analysis, and then they found that the risk, although the transmission rate, as we know from way back, goes up from 36% in the first trimester to 66% in the third trimester, it is actually very rare if that is a fetal insult if the fetus is infected in the second or third trimester. So although the transmission rate increases as the pregnancy carries on, the chances of sensory neural hearing loss or neurologic adverse neurodevelopment really drops to very close to zero if the maternal infection occurs after 40 weeks. Now, this is all very well and to know, but can we prevent the fetal injury from CMV? And there has been now quite a few good studies that tell us that valacyclovir 8 grams a day decreases the vertical transmission. And what it basically does, it delays the vertical transmission.
Sorry, sorry, can I just ask you,
Yes.
acyclovir, how many grams a day?
So that's not acyclovir. This is what's it called, ganciclovir.
Okay,
So
and
that's
what dose?
8 grams a day. So that's 2
8
grams.
grams.
Yeah, so that's a huge dosage. And of course, so this is also going to be really expensive, but you really need to give it. But we'll get back to that from the time when you pick up seroconversion up till probably 17 weeks.
Okay, thank
And
you.
because what it does, it basically delays the transmission past the placenta. And if you can delay it until after 14 weeks, then you know the baby's going to be fine.
Right.
And so basically the plan is then, and that's just Eve in full battle cry. And this came from him and is now in the new European consensus statement, is basically if if you detect seroconversion, and that basically means that the patient needs to have a CMV IgG as soon as you know she's pregnant. That's repeated every 4 weeks or maybe even a little bit more frequently, practically up to 14 weeks, because she now seroconverts, you're not worried about that anymore. If she seroconverts, let's say at 10 weeks, then you give the ganciclovir till 17 weeks, do an amniocentesis. And you know, if we go back to this little slide, that, there's at least a 50-50 chance that the CMV wouldn't have reached the fetus. And then you can stop and go back to a completely normal pregnancy. If it's positive, then there is good, also at least reasonably good evidence that continuation that decreases the number of severe fetal lesions. And some parents might say, well, if I find it in the amniotic fluid, I might not want to carry on with the pregnancy as has been done before. So in terms of the tertiary prevention, we also know that if there are mild ultrasound features, this is now a different scenario. There's now a patient where you don't know when the fetus got infected and you see mild ventricular megaly, bit of periventricular echogenicity, maybe a little bit of some echogenic foci in the liver, and you do a amnio or choreocentesis and find out the fetus has CMV, that there's actually, we know from people like Marlinger following up these babies that quite a large percentage of these babies actually recover. And so it's not immediately a death sentence or a script for mifepristone, but these babies can be followed up, and if they get valacyclovir, there is also a big reduction in the chances that this would progress. I'm not really going to talk about the neonatal antiviral treatment, but that has definitely a role to play. So that's the consensus statement that you can find in the Lancet, and it's one of the free Lancet papers that you can just download. And it has been taken over by two of our local laboratories that now actually has preempted our new SASWOC clinical guidelines on congenital CMV diagnosis and management during pregnancy. And although much of these guidelines hasn't changed, because we still sit with a big proportion of our patients that have had infection prior to the pregnancy. In here, you can also see that there is the suggestion or recommendation that if your patient population is one that presents itself early in the first trimester, the recommendation is to follow the European guidelines to do a baseline CMV, only the IgG, because you don't want to mess things around with an IgM. You do the IgG if it's negative. You repeat it four weekly until 14 to 16 weeks. And if the patient seroconverts, or if at the first stage you find a low IgG avidity and positive IgM, then give the ganciclovir until 17 weeks. Do an amnio if the CMV is negative. Stop the treatment. If the PCR is positive, continue the treatment, and do imaging in the third trimester to decide whether there is reason to consider a late termination. And we know that the reduction of the severe fetal lesions is probably in the range of a 75% reduction. So if it is true that in our prior patients, 50% of CMV is congenital CMV is the result of a primary infection, we should be able to avoid, with a bit of luck and all the attrition that happens at different stages of the screening process, we should be able to reduce congenital CMV probably by a third. And so if we go back to the criteria for a good screening test, we really tick most of the boxes, except we don't know. The big question mark is really about, is the cost going to be beneficial? And, there's so many things to talk about to the patient early in the first trimester that I think this is something that we really should be putting into a pamphlet for the patient to read and decide, this is the trajectory. And I would say especially the patient that's seronegative with a child in a creche, that, if you choose only one patient, that would be the one. And with that, I don't think we're quite at the point where we would have been with early preeclampsia, that we can say that congenital cytomegalovirus due to primary CMV is a preventable disease, but it's definitely at least partially preventable. And it is, of course, something that's a very big change in paradigm about how we're thinking about CMV. So I'm happy to hear if you have any questions. So I don't have any pictures of Utrecht, but I have this one of my grand dog.
Of your dog. Lo, that's wonderful. I'm just going to see. Let's see, questions. Oh, yeah. At the moment, let me just ask you, as a primary screening, for primary screening for our patients, what would you suggest is the correct option in a primary screening program for women in private practice? And then is this going to be practical for women in the public sector to follow? How do you respond to that question that I've got?
Right, yeah. So I think to start with your second part of the question, it's unfortunately not going to be practical for patients in the public sector. I think firstly because the seroprevalence is so much higher that the chances of finding someone that's seronegative is much less.
Yeah.
And also we know that there's a big struggle to get patients to book earlier, so that there is a proportion of patients that do present in the first trimester, but it would really first need that paradigm shift of patients coming for antenatal care already early in the first trimester. So in public practice, I don't foresee it really being a practical option in the near future. In private practice, I think this is really something that should be discussed, and even something that should be discussed with patients preconceptionally. If you talk about, I think in general gynae and obstetric practice, there are many patients coming along saying, I want to go off my pill, and you start talking about folic acid, checking that she's immune to rubella. And now I think the other thing one would do is to check whether she is seronegative for CMV. And if she is seronegative for CMV, I think that's time to start talking about it. So that by the time she falls pregnant, basically as soon as she does her beta ICG with your local friendly lab, that would be the time to get a CMV IgG.
Okay, thank you. Now another question over here. Seeing that this is a virus, is there any possibility of vaccination if a woman is seronegative?
Yeah, so possibly in future, and we know there's been a great progress made with the HI virus, and it might be that the CM virus is next in line, but I'm not aware of any large amount of money being thrown at the problem of a vaccine for CMV. So I'm afraid that's still something that's not going to be, that we're unlikely to see within the foreseeable future.
Do you think it's theoretically possible to design and manufacture a vaccination for this, or is there some reason, perhaps antigenic shift, that makes that impossibility?
Yeah, so that's beyond my pay grade. I don't know.
Okay.
That we'll have to ask our local friendly virologist.
Okay. Now let me just check here. Oops. I'm just looking to see if there are any other questions. Chris, I don't see any other questions. Do you see any other questions, Chris? Not.
No, I do not see any other questions, no.
Okay. Well, in that case, I just want to ask one or two things. Lo, the first question is, are you going to be presenting a SAS of yourself in August?
I'll definitely be at one of the pre-Congress workshops. There will be one on the heart of the grey matter, on the brain and heart abnormalities.
Okay, that's scanning abnormalities that are possible for pregnant women, and you're going to be presenting that workshop. And what did Mike Balfour, who used to be my registrar, what is he going to be presenting?
He will be talking about fetal therapy. I'm not certain yet whether it's a separate workshop, whether it's at the workshop or whether it's in the main program.
Okay. All right. There's another question just come up. Let's just see what that says. It's from Sam Monokwane. Ganciclovir and valacyclovir Zelitrex are antivirals but differ, as ganciclovir is primarily used to treat CMV, whereas Zelitrex is for herpes. Please comment. Are you able to comment or not, Lo?
Yeah, so I mean the GAN cyclover is the one that's been used in the CMV, and I think if one were to use something, that's what we should be using.
Okay. Do you have any idea of the cost of 8 grams a day for a couple of weeks?
I heard that, and it doesn't come cheap, but other than that, I can't tell you. I should have found out the cost of that, also the CMV IGT costs, but which fortunately are not. That's fortunately not all that much in the greater scheme of things. But I can't say.
Yeah, I
It's
think
going to
the right
be.
question is this: is it cost effective? No matter what the cost is, if you're going to prevent CMV infection in the
Yeah,
newborn, that's a different question. Would you say,
that's
I
right.
see you nodding your head, is
Yeah,
that likely
yeah.
to be?
Yeah, if you work out the number of cochlear implants that would be avoided, then I am convinced that it will be cost effective.
Okay. Well, ladies and gentlemen, it's been wonderful having Lo Pistorius here with us this evening. Lo, thank you very much for your time. We look forward to seeing you at SASOG, and we look forward also to having Mike Belford over there. It's been great to have Chris here with us. And one last question, Chris, for people that don't get, that have registered, that don't get their CMV points or that don't get their CMV questionnaires, what would you suggest to them?
Well, I would hope that it's CPD points rather than CMV points, but yes, we have had
CMV
some.
points. CMV points.
We've had some recent problems, but we are working on those, and so I'm beginning a little bit of an audit, going back to see for those who've possibly missed their CPD points. So we are working on it from our side as well. But yeah, we are aware, and we'll be sending out some links just to reopen some of the lost quizzes, perhaps, or the ones that were returned erroneously. Yeah, so we will be sending out links to correct all of those CPD errors or goblins, as you refer
And
to
the
them.
and the other thing is this, that you are working as we speak on an AI app to make it much easier for people to download. I mean, for example, in Lowe's Talk, if you wanted to download that, the app that you're working on would make it terribly easy. Is that correct?
That's correct. We're trying to recreate the system completely, making it an app that would make it a lot easier for the people to do their CPD points and get them and make the whole process more error prone.
Okay. So,
Yeah.
ladies and gentlemen, can you tell us, Chris, do we have a presentation or is it varsity holidays next week?
No, we have one more presentation before the holidays, which will be Dr. Creer. Dr. Creer is speaking
Oh,
next week.
yes.
Yeah,
Yeah, Professor Tinskria, he's
yeah.
an expert on male infertility. We've been asked many a time, to talk on male infertility. Minjeev has been on my neck for every week. He says, when are we having male infertility? So next week, ladies and gentlemen, I urge you to be present for male infertility. Thank you. Wonderful talk, Lo, as always. Been very kind of you. We look forward to your talk at SASOG. For those 100 people that have logged on, it's wonderful to host you. And a special thank you to Chris as well. Safe home all. And we'll have, hopefully, Steve Jeffrey will be back from Azerbaijan next week, and he can be with us for that occasion. Thank you, ladies and gentlemen. Thank you very much indeed. Safe home and good night to you.